I'm Paul Stolee. I'm a professor in the School of Public Health Sciences at Waterloo. I'm part of the Geriatric Health Systems Research Group that has been connected with SHARP for quite a few years. I'm also the director of the University of Waterloo Network for Aging Research. And so I'm going to talk briefly about some work that network did that involved SHARP members some years ago. And that was an exercise to set research priorities that led, the one culminated in a symposium. So let's maybe go to the next one, Alex. So Network for Aging Research, or NAR, is a group of aging-focused researchers from the University of Waterloo. We have over 100 members, and we also have, I think, over 200 community members who have linked themselves to the network. Our role is to support aging-focused research on campus, and we've been doing that through catalyst grants, small grants that help researchers get their programs of research started, and by supporting a number of events. So one thing we did in 2017 was undertake a priority setting process to guide the subsequent grant calls. The process for that was, first we did this online and paper survey that asked respondents to say, what questions should aging researchers focus on answering? And that went to many people, including SHARP members, other community members, members linked to the Schlegel Research Institute for Aging, and so forth. We got the results of that back, and we organized the results into a number of themes. And then we took those themes to this NAR Spring Symposium in June 2017. And for those of you who were there, that was the one where we had Olive Bryanton as a guest keynote speaker. She was at the time doing her PhD at University of Prince Edward Island, and she's finished now. You can see in this picture our very sophisticated voting procedure for assigning priorities, which involved putting your blue dot on something you thought was important. People also had a chance to identify other things they thought were important, but weren't on the list. So we can go to the next one. There were, I think, 83 participants at that symposium. There were 1,029 votes on the different priorities. There were 29 priorities that came from the previous survey, and then 9 additional priorities were identified throughout the day. And then the top 10 were these ones. And I think you can see how well considered these turned out to be. The number one being social isolation, which became an even more important issue during the pandemic. And other priorities: promoting healthy living, care coordination, dementia, age-friendly communities, support for family and caregivers, aging in place, mobility, rehabilitation, and leisure. So some very, I think, well-considered priorities that we then used to guide our Catalyst grant program. So that's on the next slide. So we sent calls out to researchers at Waterloo for proposals to do research projects, and we encouraged them to align their projects with one of those or more of those top 10 priorities. And we have since funded 16 grants of up to $20,000 each, for a total of almost $240,000 in those priority areas. And you see in the next slide, this one, that has resulted so far into 14 research papers published, over 30 conference presentations on that work. And what's very meaningful for us is that it also resulted in 10 successful external grant applications for a total of more than $3.2 million. So what we hope with our Catalyst grant program is that with the data that researchers collect through that small scale project, they can then look for funding from outside the university for a larger scale project. And that's exactly what happened. Give you a couple of examples here. One was this project from Mark Aremus in Faculty of Health, Jane Law in the Faculty of Environment did a project on social support, availability, and cognitive function in middle and older aged adults. So that related to both the social isolation and dementia priorities. That work has led so far to 4 peer-reviewed publications, 9 presentations, and 2 external grants, one of which was a CIHR operating grant for $200,000. So that's what we would consider a success story for that project. And another example, this one on the efficacy of a smart watch for exercise performance evaluation, priorities related to mobility and rehabilitation. This work has led to publications which are underway, a couple of presentations, but already a CIHR grant of close to $1 million and a workplace safety and insurance board grant of over $250,000. So the research priorities that the SHARP group and the other participants identified have been used to guide University of Waterloo researchers into directions that have then led to significant external funding and progress on those research aims. So then what's next for NAR? We're planning another call for research proposals in the coming year. We are hoping to undertake another conference in the coming year. We did one last year with the Center for Bioengineering and Biotechnology. It was quite successful. That was on aging, COVID-19 and technology. And something similar may happen in the coming years. So look for that. We also will be running another William Forbes lecture. So William Forbes was the founder of the gerontology program at Waterloo. And we've been running an annual, or hope to be annual lecture series. So we don't know who the speaker next year will be, but we would be happy for suggestions from this group now or later on what you think our research priorities going forward should be, and on what you would like to see a conference focus on, a conference that brought researchers and community members together on issues of joint interest. So that's all for me on that one. And I think we're going to have the question and answer period sort of at the end, but first move through the presentations. So I'll pass it over to Jacobi and Susie.
Great, thank you. So maybe I'll just introduce myself first and then hand it over to Susie, who will introduce herself and get us started. So I'm Jacobi Elliott, and I wear a couple of different hats. My full-time role is as the evaluation lead in specialized geriatric services at a hospital actually in London. But I am still affiliated as a research scientist with the University of Waterloo and hold an adjunct position both at the University of Waterloo and Western University. And I'll hand it over to Susie.
Yes, but you can't forget to say that you are a new mom too, and that's the most important position of all. Hi, everybody. I'm so pleased to be here today with the University of Waterloo, and I also wear several hats across Waterloo Wellington, one of which is a mom as well, of a younger one, who not as young as Jacobi, but my daughter is turning 8 now. And so I recognize many familiar faces, probably from my other work, which is working across Waterloo Wellington between the primary care and the geriatric system. It's lovely to see you here, Dr. Skillman, and I'm glad that we are reacquainting ourselves with each other and that you've joined this most wonderful group. So as Jacobi mentioned, we're going to tag team a little bit on this presentation. And so today I'm wearing my role as a researcher with the University of Waterloo and have been privileged to be involved in various projects that have informed the one that we're talking about today, which is transforming primary care for older Canadians living with frailty. So next slide, please. Okay. So our research group at the University of Waterloo has been very blessed to conduct extensive consultations with more than 1,000 older adults, I'm sure folks like yourselves and perhaps yourselves as well, and healthcare providers across various research projects and workshops. Because of all of this research, it's what we've determined and what won't be new to you, but it's well recognized that primary care should be the hub of care coordination for older adults to encourage an integrated system of care, a system of care that links primary care with other sectors of the healthcare system, for instance, home care. So for many folks, like yourselves, as well really as any of us, primary care is really where we enter the healthcare system. It's the gatekeeper, or what we might call in the research, the medical home, where people can be linked to other providers and services. The primary care setting presents an opportunity for a broad impact, reaching the greatest proportion of patients like ourselves and older adults at the earliest point in time. It enables us to facilitate referrals based on patient need and preference. And so if we can intervene at this place, the place of primary care, we can have the greatest impact on the rest of the healthcare system, inclusive of ourselves and our own healthcare. Next slide, please. Our research group at the University of let me move my slides. We also know that older adults are high users of healthcare services, and the current health system is really not meeting any of their needs. Primary care seems like a reasonable place to care for folks. We also know that there are many challenges with the current system in Canada, which have been made much more, newsworthy during COVID, as we've all seen. We know that older adults experienced rushed office visits, a lack of care planning and coordination. And we also know that older adults just haven't been trained well enough to manage their own care. Now, for some of you, this may very well be the case. And for others of you, I think we're seeing a change, that people are beginning to speak up more than would have happened in the past. But we know that if that doesn't happen, it can lead to poorer health outcomes for patients, as well as preventable and expensive visits to the emergency department or hospital. And for many of you, you will know that most grant applications nowadays ask for comments to be made or research to be done or data to be collected specifically around emergency department visits. Next slide, please. So based on all of this research that has been conducted with health professionals and folks like yourselves, our research team at the University of Waterloo entered into an opportunity to put forward a research question. And this research question is, compared to usual care in primary care settings, does a proposed model improve health, social, and economic outcomes for frail and at-risk older Canadians aged 70 or older? And basically, what is this model that's being proposed? This model, again, was based on all of the conversations that have been had, as well as previous research over the years, which would indicate that it's important within primary care to have consistent screening and assessment of frailty, to have good care coordination and system navigation, to have enabled an environment where both patients and caregivers can engage in that shared decision-making with healthcare professionals by having the opportunities to utilize current technology supports if and when required. Next slide, please. So with our research question, we entered into an opportunity to work alongside 8 primary care practices across 3 provinces in both urban and rural settings. We have sites located in Alberta, Ontario, and Quebec. Our expected sample size was about 70 participants from each site for a total of around 630 people in both of our starting group as well as our group with which we would administer our model, of which Jacobi is going to talk about more. And maybe if we can move to the next slide, I'll just do a bit of an introduction for that. Great. So as I mentioned, our research question was really looking at a model of care in primary care that consists of a red circle, which is consistent risk screening and assessment using a quick risk screening tool called the Inter-RAI Assessment Urgency Algorithm, or the short form, which we're good at in healthcare, which is the AUA. We also, as part of that model, would introduce patient and caregiver engagement and some shared decision-making tools, which are part of the orange circle that you can see. And so we would encourage our healthcare providers to enter into conversations with their patient with the context of what we call the choice framework. The choice framework is based on previous experience and research, and it really looks at a variety of important components to help engage older adults in decision making. Alongside of the choice framework is also the introduction of 5 shared decision-making tools, which Jacobi will talk about. Another important part of the model is care coordination and system navigation, which is the purple bucket or circle. And we were utilizing within this model CareDove, which is an online referral platform that helps to link patients to services. And finally, we were able to utilize several different technology supports. So we were able to look at and wanted to look at putting our risk screening on tablets or having it embedded in the electronic medical record that your physicians would use in their offices. We looked at having CareDove available to our health service providers right on their own computers in the office, with patients being able to access CareDove from home if they had access to a computer, or to leave with some information in their hands related to CareDove. So I'm going to pass it over to Jacobi now for a little more explanation around each of those components.
Great, thanks so much, Susie. So as Susie just mentioned, I'm going to go through each of those tools in a little bit more detail and with some visuals here on the screen. So the first tool that we're going to talk about is that screening tool. So that Inter-RAI preliminary screener, also known as the assessment urgency algorithm, the AUA. So this is a screening tool for people 70 years of age and older that would help clinicians determine if someone needed more support or were at risk of going to the emergency department. There are a number of questions. There's about 9 questions on this tool, and it is really quite a quick screening tool. In practice, it takes maybe 2 minutes to complete, but the questions focused on cognition, also focused on independence. So asking the patient if they can bathe themselves, dress themselves, move around their home okay. There were also questions that looked at self-reported health and mood, shortness of breath. There was a question for caregivers, so asking if caregivers were overwhelmed in their caregiving role. And we also added in some questions around nutrition. So again, this tool really helps providers know if the patient is managing well or if they need to do anything further. So any further assessment with the patient or referring the patient on to specialists or other physicians. And next slide. We also implemented some documents that we called decision boxes that help with shared decision making. These documents compile all of the best available evidence about a particular topic so that a patient can make an informed decision about treatment. So I'll just share one example. So if a patient is noticing a decline in their function or their movement, they would look at the decision box around functional decline and maintaining autonomy. The decision box would offer treatment options such as yoga, physical activity, brain exercises, physiotherapy, options for making their home a smart home. And with each of these different treatment options, there's associated risks and benefits. And again, this is all grounded in available evidence. This allows the patient to make an informed decision about which treatment option they would like to choose. As you can imagine, if we looked at all of the available evidence, these decision boxes can get quite long. They're about 15 pages each. And we heard feedback that it was very overwhelming to present these decision boxes in clinic to older adults. So you can see here on the screen, we actually worked with some of our SHARP members to take that 12-page decision box and make this short 1-page back and front document that we really hoped would be less overwhelming, but would share that need to know information, again, so that patients can make informed decisions in partnership with their healthcare provider. Next slide. The last tool that we implemented was the platform that Susie mentioned called CareDev. This is an online tool that helps people find services available to their home. So they would enter in their home address and then select a different type of service that they might be looking for. So services like transportation services, home exercise programs, Meals on Wheels, things like that. We heard that it's hard for doctors to keep track of all of the different services that are available in the community for their patients. So again, this is just one tool that really helps physicians and healthcare providers in primary care know about all of the different services that would be available. And this is also a website that, that anyone can access. So you as a community member can go on and type in your address and see what's there for you. And next slide. So prior to March 2020, we were able to train and implement the tools in 6 of the 9 clinics across Canada. We were all set to start our data collection right about the time that the COVID-19 pandemic hit. So we did make a decision as a research group, our colleagues from across Canada, to stop all research activities during this time. It was interesting to see that some of our clinics continued to use some of these tools while they were conducting some virtual appointments with patients. Next slide. So we have, as I mentioned, stopped all research activities. However, we have learned a lot about how to tailor the tools to different provinces and in different clinics, and how to implement the tools into practice. So we are in the process of creating documents to help healthcare providers learn more about these tools and how they can implement these tools in their own practice. But we also want to share this information with older adults. So again, sharing what we learned about CareDev and shared decision-making and screening with older adults across Canada. Next slide. Oh, sorry, there we go. Perfect. So we are hoping to create some of our resources that we are calling public-facing content. So content that would go out to the general public that would share information about our tools. We are hoping to get feedback on these resources as they're being created. So if anyone is interested, please let us know, and we will be reaching out to the Broad Shark group in the coming weeks to see if anyone is interested. I will pause there. I think the next couple of slides just show the number of organizations and partnerships that went into this project. Thank you. Over to Lama.
Hi everyone, my name is Lama Abdallah and I am an undergraduate student at the University of Waterloo, and I completed 2 co-op terms with the Geriatric Health Systems Research Group over the past year or so. And I'm going to be talking about a project that I've been involved in for the past couple of months that focused on the experiences and perspectives of older adults with regards to virtual care during the COVID-19 pandemic. So we can go to the next slide, please. Thank you. For this project, I'll start us off with a definition. We defined virtual care as any interaction between patients and or members of their circle of care that occurred remotely using any forms of communication or information technologies with the aim of facilitating or maximizing the quality and effectiveness of patient care. So this essentially means that virtual care is anything that occurs at a distance that is healthcare and that occurs with the use of technology. Next slide. Thank you. So now for a quick summary of our background and our purpose for the project. As many of you have likely experienced or seen over the past couple of years, the COVID-19 pandemic has caused many providers to switch to virtual methods of care delivery instead of in person in order to limit the spread of the virus and to protect patients from becoming ill with COVID-19. In this study, we sought to understand the perspectives of older adults on virtual care during the pandemic and to ask them how they felt about their virtual experiences and how they felt about the future of care after the pandemic. We interviewed 20 older adults at 2 different time points during the first wave of the pandemic in 2020 and the second wave of the pandemic in early 2021. All the interviews were completed by telephone or video call and transcribed. We then analyzed the transcripts to find common themes in the data using in vivo. Once we identified the themes, we reviewed our findings with 4 participants of the study and 5 members of SHARP in 2 focus groups. And that happened a few months ago. And we presented our findings and asked for feedback and reflections. In the interviews, which focused on older adults' digital connectivity during the pandemic, the virtual care related questions focused on technology skills, virtual appointment experiences, perspectives and receptiveness towards virtual care, the pros and cons of virtual care, and the preferences for the future of virtual care after the pandemic is over. The next couple slides will provide a summary of the key findings and themes that we identified in the data. The 3 main proposed benefits of virtual care that our participants highlighted are convenience, safety, and efficiency. Virtual care makes appointments more convenient because they typically require less time due to not having to wait in a waiting room or to physically travel to a clinic or to a hospital in order to receive the care. Participants also found it was more convenient to be able to receive and send documents virtually instead of having to physically go to their provider's practice in order to pick up paperwork like requisitions or test results. So they found it really easy to be able to just email those or send them by text message or receive test results by phone. Participants found virtual care more safe because it allows patients to avoid unnecessary trips in bad weather, for example, and to avoid potentially picking up an illness from a waiting room or from interacting with other sick patients in a hospital. Finally, participants found virtual care more efficient because they found that it made appointments more easy to streamline for providers and that it makes it easier to communicate with a large team if you're trying to communicate with different providers. The proposed limitations of virtual care include a lack of verbal communication, like facial expressions or body language, which help both patients and providers express themselves better. Another limitation is that some older adults do not have access to the technology necessary to engage in virtual care, or if they do have access to the technology, they don't necessarily know how to use that technology. The lack of physical examination is another limitation that participants commonly pointed out, as providers aren't able to be tactile in their examination and actually feel anything that they would need to feel. Participants also mentioned that care continuity and coordination can suffer in virtual care as appointments had become more spaced out, which caused a lot of our participants to be concerned that something would be missed in that huge gap between appointments. Finally, some participants mentioned how an in-person appointment can be a key social event in the lives of older adults. So they thought that switching to virtual appointments would cause older adults to miss out on that social event, increasing the social isolation and depriving them of the chance to enjoy a visit with their provider. When we identified these themes, we tried to go with the majority of what the majority of participants felt. However, it is important to note that what may count as a benefit for one person may present a limitation to another person. For example, while some patients may appreciate the increased efficiency of appointments, others may feel that appointments have become rushed and might prefer in-person appointments instead of virtual efficient appointments, as mentioned. Okay, another important theme that we identified is the receptiveness of participants to receiving virtual care. We found that most participants were open to receiving virtual care, even if it wasn't their preferred mode of care, especially in circumstances like a pandemic when it was required to limit contact, physical contact with others. Many participants also identified that they and other older adults that they knew would be willing to learn how to use technologies for virtual care and how to learn to use new technologies if necessary so that they could access virtual care. Finally, participants emphasized a need for training and for supports to be created for both patients and providers in order to improve the experience of virtual care for older adults. This brings me to the future of virtual care, which was another theme in our research. When we asked participants how they would like the healthcare system to look after the pandemic, about half of the participants said that they would prefer returning to mostly in-person care, like before the pandemic, and the other half preferred a hybrid system where services would be offered virtually and in person, and they could kind of decide which services to access in person versus virtually. Next slide, please. Thank you. So as a result of our analysis of what supports participants would like to be implemented for virtual care and the comparison of existing tools to support patients, we created a virtual care tool to help older adults get ready for and navigate virtual care appointments, which is on the screen right now. So we conducted 2 focus groups during the summer with SHARP members to ask for feedback and suggestions on the tool, and have implemented them into a second draft, which is the one that you can see right now. And we titled it Getting Ready for Online/Phone Appointments, with a list of things to prepare before the appointment and areas to take notes during the appointment. And this brings me to our next step for this project, which will focus on the continued creation of the virtual care preparation tool. As part of my honors thesis over the next year, I hope to spend the next few months recruiting older adults to test the tool in appointments in order to see if we are missing anything important and in order to finalize the tool. After that, we will focus on distributing the tool to older adults and providers and other sources that can pass it along to patients. With that being said, if anyone is interested in helping to test the tools in appointments or in helping to distribute it to the community, please feel free to let us know. We would love for you to be involved. And that brings me to the end of my presentation. Thank you all for listening, and I'll pass it on to Diya.
Thank you, Lama. Hello, everyone. I am a first-year PhD student with the GHS team. I am an international student. I did my undergrad at Waterloo, at the University of Waterloo, and I'm now doing my PhD here as well. So I'll talk briefly about the RIOA grant. So RIOA is Racialized Immigrant Older Adult grant, which is a Canadian Institute of Health Research grant titled Developing Strategies and Resources to Support Patient and Family Engagement with Racialized Immigrant Older Adults. So we've consistently heard from SHARP members that they recognize that SHARP consists largely of individuals from a Caucasian background. And it was brought up that we should do research with more diverse communities, which is more reflective of the Canadian aging population. Dr. Stolee, Dr. Tong, and I agree, and that's one of the reasons we're engaging in this current project, where we are looking to understand the experiences of racialized older adults within the healthcare system and looking to develop tangible solutions for those challenges. So one of the first things we've done within the scope of this grant was conduct a pilot study specifically focusing on the South Asian cohort. So South Asians are one of the largest and fastest growing racialized groups in Canada, but the culturally unique health needs of this population are not comprehensively studied. So to support the health and well-being of racialized immigrant older adults in an equitable and culturally competent manner, it is first important to recognize how the population perceives and understands healthy aging. To that end, our research question in the pilot study was, how do foreign-born South Asian older adults in Canada define and conceptualize the notion of healthy aging? Next slide, please. So the methodological approach that we had was in-depth focus groups and interviews, which were conducted virtually in 5 different languages. We recruited purposefully and through voluntary snowball sampling strategies within Southern Ontario. And the team basically sat together and we did team-based line-by-line analysis of the data. So we had 19 individuals in total from 4 different South Asian countries. Next slide, please. So drawing on the comprehensive responses in the interview and focus group, our analysis illuminated 3 prominent themes that were related to healthy aging: taking care of body and being, taking care of mind and heart, and healthy aging through the integration of mind and body. So participants believe that healthy aging extended beyond simply the absence of disease and longevity. The quality of life, including the quality of food, social connection, and the environment, was highlighted as key determinants of healthy aging. We concluded that the influence of culture remained central to and informed their conceptualization of healthy aging, further reinforcing the fact that immigrant older adults are a diverse and heterogeneous population, and that the culture of their country of origin is heavily influenced in their approach to healthy aging. Next slide, please. So after the completion of the, sorry, Alex, the previous slide. Perfect. So after the completion, oh, sorry, my bad, the slide after this. So after the completion of the study, we are now undertaking the larger RIOA study that will answer the following questions. So how do RIOAs navigate the healthcare system? What roles are they taking or not taking in managing their own health or healthcare? And how do RIOAs approach healthcare decision-making and engagement with providers and family members? Next slide, please. So what we're doing is we're doing more in-depth interviews with older adults surrounding the 3 primary questions. So this term, from fall to January, we're looking at the South Asian cohort, and we are recruiting for 15 participants, 15 healthcare providers. In the following months, from January to May, we're looking at Arabic-speaking older adults and also 15 participants with the inclusion of 6 to 10 medical interpreters. We're also looking at Chinese older adults months to follow after, where we're looking at 15 more participants. Next slide, please. So we've already conducted about 7 interviews so far with the South Asian community, and here are some of the prominent themes that are listed here that were brought up by the participants, essentially. So one of the things that we really heard from participants was the idea of virtual care and the challenges or benefits associated with it. So particularly participants with language barriers and also those who are newer immigrants, they have really stressed the idea that virtual care has been challenging throughout the pandemic. For immigrants who have been here for longer, though, they have been really appreciating the convenience of virtual care and being able to virtually speak with the providers. Another theme that was brought up by participants was the need for compassionate care, stressing that when interacting with healthcare providers, it's important that they're spoken to as human beings and not as patients, and highlighting the need for human-to-human connection that is carried out in a compassionate way. There's also been interesting findings around how interactions with providers can be influenced by the gender of the participant, and also the role of family in healthcare decision-making can be quite prominent. Next slide, please. So the longer-term goal in RIOA is not just to understand the context in which racialized immigrant older adults are engaging with the process of aging and the healthcare system, but also to co-design solutions. So our plan later next year is to sit down with some of the participants and healthcare providers, and based on what we've heard, look for solution, whether it's better information kits or cultural competency guides for providers, or something to help immigrant older adults better navigate the healthcare system in Ontario in their own languages. But a big part of the co-design process is that we don't actually know, or rather even want to know, what we're going to create until we hear from the people about what they need. So in conclusion, not only are we trying to understand the system and people's experiences of the system, but we're actually actively trying to improve the system for older patients of all cultures, ethnicities, and statuses. Thank you. Over to Jacobi.
Or to Catherine. Thank you. No worries. Thank you very much, Diya, for summarizing that project. And I'm going to go rather quickly through these last slides because I'm really excited to hear from all of our members. So Dr. Stolee started talking about the NAR grants, and one of the NAR grants that our team was awarded, and he doesn't vote on the ones that we apply for, other votes from across the university do so. We were funded a grant titled, "Where Do We Go From Here? Older Adults' Perspectives on Care in a Post-COVID Era." And that's led by Dr. Jacobi Elliott, colleague Jennifer Dean in Environment Studies, and a few members from the GHS group. And this project's always been done in close collaboration for SHARP, because it was actually some SHARP members' idea. So they're not here today, but John and Donna Spears had both suggested that we should look at this, look at the questions. Next slide, please. So we're calling this a participatory action research project. And as you've seen today, we don't just do research, we're really trying to take research and get into the hands of the people who need it to actually make a difference in the lives and patient experiences of older adults. But especially with this project, the idea is not only are we collecting data, we also want to do an advocacy piece to accompany what we hear in the data. Next slide, please. So we wanted to understand how have our older adults thinking about care options in later life? So how are they feeling about home care, long-term care, aging in place, and how has the pandemic shaped their thoughts? And particularly, we want to understand how can we better support older adults who do want to age in place, who want to stay living in their homes and communities for as long as possible. How do we make that happen? Next slide, please. So far we've done 9 telephone or Zoom interviews with older adults, 3 with caregivers. So we're in process, we're not done yet. And what's been nice so far is we've had varied ages, genders, geographies, socioeconomic statuses. We've had folks in rural towns, folks closer to town here in Waterloo. We've had people living in long-term, or people talking about others, like family members who live in long-term care, people who live in retirement homes, and those who are community dwelling. But again, because of this advocacy piece, and the advocacy piece really came from SHARP members who said, yeah, we want to understand how people are feeling about home care, but we actually want to raise the profile, and we need to communicate to the powers that be, to politicians, that this is something that needs to be addressed. So in that spirit, we've been working really closely with a number of community partners to sort of set the background to do a bit more advocacy work. So far we've connected to Provis. We spoke to them yesterday. After that, some women from the University Women's Club of KW have reached out. And through our principal investigators, we're also connected to the Provincial Geriatric Leadership Office, SC Health, and other community organizations. I think the key thing here to say is, yes, it looks very small. We've only interviewed 12 folks, and we're probably not going to interview more than 20. But the fact of the matter is there's 20 years of data in Ontario and across the country that shows seniors want a more robust home care system. And 91% of older Ontarians have been surveyed want to stay living in their homes and communities for as long as possible. So when we're speaking to older adults for this research project, that's the overwhelming sentiment. People want to stay living at home for as long as possible. When it gets to long-term care, we hear a range of things from I would never go to long-term care to, long-term care is the best thing that could ever happen to my dad because he's so much safer. Same for when we ask people about home care. Some people, even during the pandemic, have had fantastic experiences with home care, and others, unfortunately, have not. I think the point is, and what our participants have really highlighted, is it really varies. It varies by where you live, the facilities you're in, the providers you're working with. But what we consistently heard and what the data has already shown for a very long time is that older adults want to stay living in their homes and or communities, and that home care is the answer. Sue Vanderbent, who's the CEO of Home Care Ontario, that's the association that represents more than 50 home care providers in this province, said in a recent opinion piece, home is where seniors want to be. Now is the time to contract, not to contract, but to expand home care. And for context, recently, and this is a good move, the Ontario government committed $300 million to expanding home care services. For context, that's less than 1% of the overall healthcare budget. And for context, starting next year, they've committed to $1.9 billion to improve long-term care. So we are not yet expanding home care. Not enough, at least. And Dr. Samir Sinha, who's a highly respected geriatrician and who's worked on aging strategies both provincially and nationally, has said, this is the rare opportunity when what people want you to do is actually the cheapest thing for the government. And in my Probus presentation yesterday, I kind of walked through evidence internationally, but also from Canada, that shows when we spend more on comprehensive and preventative home care, we save the system money in a couple of different places. We see fewer transitions to long-term care, fewer ER visits, and a host of better health outcomes for the people receiving a more comprehensive, robust, and preventative basket of home care services. So Dr. Sinha has said, this has left me scratching my head. If it saves money and if it's what people want, why aren't we doing more of this? Next slide, please. And we feel the same. So when I was speaking, we've sort of been talking through this with some SHARP members. And the idea for this grant was not only do we want to understand what older Ontarians want, we want to communicate that in a meaningful way to policymakers. So some of the suggestions so far have been a social media campaign targeted at politicians. The main idea that we've been bantering about with a couple different community members and SHARP members is to start a legal petition, particularly with an election on the horizon. That might be a good opportunity. So I would love to hear from you in the bit of time we have left today. What do you think our next advocacy step should be from SHARP, and hopefully in partnership with others, to really raise the profile of home care and make sure that the politicians know that we want a government that's better investing in more robust home care services for seniors. And that's all I have to say for today. Thank you.